of you and hopefully much more online that are joining us. My name is Sixto Giusti, and today we're going to talk about what you should know about giving kidney donation. I want to thank the PKD conference for inviting me. I tend to speak fast, sometimes I have a low tone and accent, so feel free to stop, raise hands, and I can gladly ask all the questions during the presentation or even at the end too. So I think this is the QR code for patients to scan and submit their question through Slido. This is the activity disclaimer. In terms of the disclosure, I have nothing to disclose. In terms of bio, I was born and raised in San Juan, Puerto Rico, did part of my training there. I finished my kidney and transplant training in New Orleans. I worked at Tulane as the medical director for a couple of years, and most recently was recruited here to actually start the Colorado University to help build the Hispanic transplant program. And I'm definitely passionate about living kidney donation. So today we're going to try to understand the living donation process, try to identify the characteristics and criteria of a good living donor. And we're going to be able to recognize the potential risks and benefits associated with living kidney donation. So if you're a donor or you have a loved one who is interested in living kidney donation, I want you to have the basic information to feel comfortable and comfortable to go to that interview or understand what needs to happen for you to be safe and for the recipient of the living kidney donation. So as a background, autosomal dominant polycystic kidney disease affects up to 12.5 million people globally, and it is the fourth leading cause of kidney failure and renal replacement therapy or dialysis. It is characterized by bilateral renal cysts.
There is no sound on the online.
And requiring transplant in up to 50% of cases.
So what's the issue? There's too many patients in need of organ and there's not enough donors. To further compound that, we have very low rates of creatinine transplantation, meaning unfortunately our patients are not referred as early as we'd like for transplant, and that leads them of years of waiting time for a deceased donor transplant on the waiting list. Living donation is one of the ways that we can overcome this. So what is living kidney donation? So living kidney donation is when a kidney from a healthy living donor is removed and placed into a recipient whose kidneys no longer function properly. Only one donated kidney is needed, and usually it will be in the right lower quadrant or in some cases in the left lower quadrant. But usually one is only needed. So who can be a living kidney donor? Any individual who is in good physical and mental health and is older than 18 years of age can be considered for living donation. Realize that medical conditions such as high blood pressure uncontrolled, diabetes, malignancy, certain infections like recurrent urinary tract infections, or an uncontrolled psychiatric condition can prevent you from being a good living donor. So what are the types of living kidney donation? We have directed donations. For example, if I want to donate to my spouse or my daughter who's going to get checked, I'm going to be considered a directed donor. In the event that I'm not compatible with my wife or my daughter, I can consider paired donation. What is paired kidney donation? So there's another pair in the same predicament when you have a donor and recipient that they don't match. They are entered into the system in which they are found pairs which are compatible. So I'll donate a kidney to somebody else, another pair, and then that other pair will donate a kidney to my recipient, and everybody gets living kidney donors. The other option is altruistic donation or non-directed donation, in which somebody who is healthy wants to help somebody else that he doesn't know. Fortunately, we have a bunch of altruistic donors, or more than the norm, in the state of Colorado. I'm guessing everybody's happy and healthy and ready to donate, but that's something unique and nice about Colorado. So let's talk about the landscape on the kidney transplant waiting list. So as of the end of 2021, there were about 140,000 patients on the kidney transplant waiting list waiting for a transplant. Of those 140,000, about 42,000 were new additions on that year. Contrast that to only about 26,000 of those patients were transplanted. Of those 26,000 transplant, about a third of them were living donation. Both have been increasing, as you can see, but I think living donor is one of the key areas in which we can increase awareness and provide more help to those patients on the waiting list. So what are the advantages to recipients of living versus deceased donor kidneys? So you don't have no waiting time. If you have a viable living donor, in between evaluation and schedule the surgery, it will take about 3 to 4 months. In contrast, if you are blood type O, for example, and you're placed on the kidney transplant waiting list without dialysis time and no donors, you might have to wait 5 or 6 years on dialysis, or at least on the deceased donor waiting list, which obviously will take a toll, and the longer you spend on dialysis, the more wear and tear your body will suffer, and it will increase your mortality. The other big advantages is we have longer graft survival, meaning the kidneys from living donors tend to last longer than those from deceased donors. Why? For the most part, donors are healthier. There is shorter colic ischemic time, which means that once you donate a kidney, that kidney will spend less time out of the body without blood supply and oxygen and on ice. So a shorter cold ischemic time will mean less kidney damage, less delayed graft function, which is delayed definite kidney injury after the surgery requiring dialysis, and less rates of rejection. And it might sound obvious, but scheduled surgery tends to have fewer complications than emergent surgeries, like the deceased donor when you will be called overnight. Come here, we have to do a surgery because we have a deceased donor for you. The other important aspect is that we have better patient survival, meaning patients tend to live longer. Comparing from deceased donor, there's a 5-year patient survival of about 91% for living donors versus 84% for those deceased donors. So how much longer does a living kidney donor last? On your left, this is the median graft survival of deceased donors, which is about 12 years. When we contrast that to living donors, we see that the graft survival is at least 19 years. So we have this big discrepancy, meaning that kidneys from living donors will tend to last longer. So as you just see, as I just showed, receiving a live kidney donor from a living person is the best option for patients with end-stage kidney disease. Nonetheless, it's one of the few areas in medicine where we endanger the health of one person to benefit another. So now we're going to talk briefly about the risks. So what is your risk or short-term risk of dying? So the risk of death within 90 days of donor-derived nephrectomy is about 3.1 per 10,000. That usually equates to about 0.026%. If we contrast that to patients who had similar characteristics but did not donate their kidney, it's about 0.4 per 10,000. Now let's contrast this to other surgeries. For example, the post-op surgical mortality for a laparoscopic cholecystectomy or a scheduled gallbladder removal is about 15 per 10,000, which is higher than both. And contrast this to the post-op surgical mortality for non-donor nephrectomy, meaning that you got a kidney removed for other reasons that other than transplant is still pretty high at 260.
Yeah, did you make it work? I got it.
So what about the survival long term?
Okay.
So the survival and the risk of end-stage kidney disease in carefully screened kidney donors appears to be similar to those in the general population. As you can see, they studied donors up to 40 years, and most donors who were studied had preserved GFR or kidney function, a normal albumin excretion, and an excellent quality of life. So what is your risk of developing end-stage kidney disease after donation? So based on this study from Mosale, published in JAMA of 2014, we can imply that in the general population, there is a lifetime risk of about 3% of developing end-stage kidney disease after donation. Live donors have about 0.9% risk. When we compare to healthy non-donors, meaning healthy individuals that would qualify for donation but did not donate, that one is about 0.14%. So we know that there is a slightly higher risk, but it's still significantly lower than the general population. So what about if you're a young female and you want to donate? What is the risk of pregnancy after kidney donation? So I'm going to tell you that compared to the general population, you will be at slightly increased risk of preeclampsia and gestational hypertension. In the general population, there's about a 2.6 to 5% of these conditions after pregnancy. If you decide to donate then and become pregnant, then the risk for both gestational hypertension and preeclampsia will increase to about 5.7 to up to 11%. This doesn't mean that you won't be able to donate and get pregnant. I have plenty of female patients who have successfully donated and become pregnant, but it's important for you to understand this risk, even if it's small. So what about the risk of new-onset hypertension after kidney donation? So based on these studies, there's a small but significant risk of new-onset hypertension after donation. On the left, we can see that at 10 years, there's about a 4.2% risk of developing hypertension in comparison to the general population, which is about 2.4%. Another important study here on the right showed us that kidney donation was independently associated with a 19% higher risk of hypertension regardless of your race. Important to note that the donors who developed hypertension had a plateau in the normal or gradual post-GFR increase after donation, meaning that if you develop high blood pressure after donation, chances are is that your kidney function might not recover completely as expected if you did not develop high blood pressure. What about obesity and kidney donation? In our center, for example, the BMI cutoff for living donors is 35. As you can see, the vast majority of donors had the BMI under 30, which is here, and about only 20% of obese donors in the States done with a BMI between 30 and 35. And you might wonder why. So, as this study showed of the effect of donor obesity on long-term end-stage kidney disease risk, adjusted for age, sex, ethnicity, blood pressure, baseline GFR, and the relationship to the recipient, obese living kidney donor had a significant risk of end-stage kidney disease. And as to put it in perspective, for each point of BMI higher, over 30, there was about a higher 7% risk of developing end-stage kidney disease. How about your age and kidney donation? In our center, the age cutoff is 70, so if you're older than 70, you won't be accepted or considered for a living donation. So on the right here, you'll see the survival of living kidney donors that are 70 or higher. This is represented by this higher graph. So in this graph, it showed that living kidney donors had a better survival when compared to the general population. This is easily explained by the fact that if you're a donor 70, you must be pretty healthy, and that's why you were selected, and that might explain this difference. The landscape over here, as you can see, most of the centers use up to 72 as well, with some few centers trying to accept more risk and accepting patients. So if the living kidney donors do well or they survive well, why are not we so hot about taking donors older than 70? As you can see here, the recipients of those living kidney donors of 70 or higher had a worse graft failure incidence and poorer survival. So if you receive a kidney if you're a recipient of a living donor of 70 or older, chances are is that your kidney is going to fail quicker. The same in terms of the kidney survival. If you receive a kidney from a living donor that is older than 70, you're going to have poor survival, as demonstrated in this lower line here. So how do you become a living donor? So getting started. First, you're going to get interested, you know somebody who wants to donate, or you want to be an altruistic donor, and you're going to identify the transplant center that you want to be worked up at. So you're going to start by contacting the transplant hospital. You enter the information, you leave a message, and then they will call you back, because they need to understand that they need to know that you're interested in doing so. So you have to originate the call. Then they're going to call you, and they're going to have an initial screening where they're going to ask you some basic questions. And if you're able to pass that, they're going to ask you to do some basic blood work to make sure that you don't have kidney dysfunction or any other major abnormality in the blood work that might preclude you from donating. In addition, they're going to plug you in with the independent donor advocate, which will make sure that there's no coercion or things like that for you to donate. So if that preliminary workup is okay, you have good kidney function and no major contraindications, you will be invited to have a full evaluation at the transplant center. As we have talked about some of the risks, I want you to be ready to discuss your risks with your transplant center. Overall, after the evaluation, if you're deemed suitable, you can decide if you want to donate or not. Like I tell all my patients, you will be always able to change your mind. Even if on the day of the surgery, if you have a second guess and you say like, hey, I don't want to do this, you let me know and I'll come up with a great medical reason why you shouldn't be a donor. I'm going to say like, oh, I overlooked the CAT scan, you have an anatomical abnormality that you cannot donate, and that way will save face with the potential recipient and at the same time save you from doing something that you don't want to do. So that's important for you as a donor to know, and that's always going to be on the table. So what are going to be the discussion points that you're going to have during that evaluation? I want you to be ready to discuss your surgical risk, realizing that the operative risk increases with age and comorbidities, meaning the older that you are and the more medical conditions that you suffer, the higher the surgical risk. Same with the medical risk. You're going to discuss with your nephrologist what is your personal risk of developing end-stage kidney disease after donation. Important point to consider is that the younger the donor, the harder it is to rule out future CKD, meaning the younger you are as a donor, the more years at risk you have for something happening to your kidney function. We're going to need to also evaluate your psychosocial risks, for example, your risk of donation and psychological status, and the potential impact on finances and insurance availability. And as I mentioned before, meet with the independent donor advocate. So what to expect? You're going to have on that first visit a complete history and a physical exam. They're going to measure your blood pressure. They're going to measure your BMI readings with height and weight. They're going to ask you about your diabetes history. They're going to ask you about your NSAID use, which is usually going to be contraindicated after donation because it will cause renal vasoconstriction or decrease blood supply to your remaining kidney and potentially hypertension. So if you need that NSAID for pain control, you probably won't be a great donor. They're going to ask you about your history of kidney stones, history of infection, and as I said at the beginning, especially recurrent urinary tract infections. They're going to ask you about your cardiovascular disease, whether you have heart attacks in the past or you have coronary artery disease. They're going to ask you about your family history with keen attention to family history of kidney disease, cardiovascular disease, and diabetes. They're going to also ask you about malignancy and other complications like pulmonary, GI, or autoimmune disease. So what lab testing to expect? We're going to check your kidney function by obtaining blood chemistry, and that's going to include fasting glucose and lipids. We're going to check your CBC, platelet, and coagulation studies. We're going to screen for viral infections like hepatitis B, C, and HIV. We're going to check for tuberculosis, syphilis. We're going to get a urine sample for a urinalysis, where we're going to check for protein, bacteria, and our blood. Ultimately, we'll measure your kidney function by GFR and protein with a 24-hour urine collection assessing for creatinine clearance. In some cases, if there is an inadequate collection, you might have to have further studies, like a nuclear GFR study. Also, we're going to ask you to make sure that you have your age-appropriate cancer screening up to date, whether it's mammography, pap smear, colonoscopy, and a prostate check. The basics will include an electrocardiogram and a chest x-ray too. In the event that you are considered at risk for cardiac complications, they might want to ask for a heart sonogram or an echocardiogram and a stress test. Ultimately, you will need a CT angiogram to delineate the anatomy and decide or determine which kidney they can procure or remove. Realizing that on rare instances there are anatomical variations which might preclude you from safely donating. There are cases in which the donor has 3 renal arteries and the surgeon doesn't feel comfortable cutting because of potential blood flow compromise, or even if you're a great donor but there's any anatomical variation, that might preclude you from donating. That evaluation will also include a tissue typing. So in that, we're going to be making sure that you're compatible with your donor. We're going to make sure that we check for donor blood group twice. We're going to get donor-specific antibodies, which will make sure that you don't have antibodies against that potential recipient. And ultimately, we'll get a cross-match in which you make blood of the donor and recipient, put it together, and make sure that it doesn't attack each other. In the cases of incompatible donors, and you have different blood type, for example, you might still be able to donate. One of the examples is the kidney pair donation exchange. Most centers have their own internal pair donation. They also have UNOS or nationwide donation like the UNOS or the NKR. So there are different venues to try to increase your pool of potential donors via pair exchanges. And ultimately, we'll get HLA typing, which stands for human leukocyte antigen, realizing that the degree of HLA matching is not as important as the compatibility. So if you're compatible, that's the most important part for you to safely donate to your recipient. As I mentioned before, we're going to be evaluating you psychosocially. We're going to make sure that there's no coercion. You're going to make sure that there's no payment for donation. There's no issues with substance abuse. There's no history of mental illness. That there's no major risk to your employment, and that you are able and willing to provide an informed consent for donation. Now, what is the goal of kidney function for donors? Below here is more or less the average of what we expect based on age to be your kidney function. So donors should have adequate kidney function for themselves and for the recipients. We usually accept up to 2 standard deviations below the mean for age. So for example, I am 40 and my GFR is 110, it will be safe for me to donate GFR-wise, and I should have enough GFR for the remainder of my life, and the recipient should have enough GFR to come off dialysis as well. So from the donor's perspective, the cutoff of 2 standard deviation is acceptable, and from the recipient perspective, the donor should have at least 80 mLs of kidney function to become a donor. So what's going to happen to that GFR, that kidney function, after you donate? So as shown here in the assessing long-term outcomes in living kidney donor studies, after kidney donation, you will be left with about 65 to 70% of your prior kidney function. So let's say that you started in about 105% of GFR, you donate 1 kidney, and that GFR will drop to about 70. And this study, which had following up to 3 years after, it showed that the GFR slowly or gradually kept increasing. In this study, published by Lam et al. In 2020 in Kidney International Journal, had a longer follow-up of living donors, and it showed that that GFR, that kidney function, continued to improve up to 5 to 6 years where it started plateauing. And they explained that one of the reasons why this happened is what we call glomerular hyperfiltration, meaning that remaining kidney after donation tries to grow and compensate and make the job for 2. So what about hypertension and kidney donation? Like I mentioned, once you go in the visit, they're going to measure your blood pressures, usually by cough, at least twice. Some cases, patients have high or higher than normal readings because they're anxious, they're running to the clinic, they might have what we call white coat hypertension. In those instances, we need to consider sending a 24-hour home blood pressure ambulatory monitoring to make sure that your blood pressures are normal. If you have hypertension, you can still be considered acceptable for donation depending on your risk and depending on the established acceptance threshold of the center. Talking a bit more about the risk of hypertension and kidney donation. Based on these studies, what I can tell you is you can have high blood pressure, but as long as your blood pressure, the normal blood pressure is below this number of 140/90, it might be safe for you to donate. So for example, Merksani et al. Found that living kidney donors with pre-donation hypertension, as long as they were below this threshold, were at no increased risk of reduced GFR or protein spillage 10 years after donation. However, like I mentioned before, if your baseline blood pressure is above that value, and at nighttime there was no non-dipping, meaning that your blood pressures who normally should drop when you sleep, if that didn't happen, that would put you at higher risk of developing proteinuria. So what about hypertension in older donors? Based on this study from Al-Amari, published in JASN in 2019, it showed that older living donors, more than 50 years of age, with pre-donation hypertension above this reading had higher 15-year end-stage kidney disease incidence compared to those without baseline hypertension. So if you're an older donor with high blood pressure, particularly above that 140/90, it might not be too safe for you to donate. So what about diabetes and kidney donation? Like I mentioned before, we're going to get a fasting blood sugar in all patients. And we're going to further inquire about diabetes by testing your oral glucose tolerance test and or measuring an hemoglobin glycosylator or an A1C if you are at increased risk of diabetes. What is considered increased risk? If you have a first-degree relative with diabetes, if you have a history of gestational diabetes, if your BMI is more than 30, or if you have other features of the metabolic syndrome, which include high blood pressure and hypercholesterolemia. Also, if you have borderline protein spillage, we will do this testing to make sure that it's not caused by diabetes. In the event that you do have diabetes type 2, that will be an absolute exclusion. In addition, if you have either pre-diabetes or glucose intolerance, for the most part, that's usually considered as an exclusion criteria. In particular, if you have other risk factors for diabetes or kidney disease. So what about if you have protein spillage, also defined as albuminuria? If you have an albumin spillage in your urine of more than 30 milligrams per grams, or proteinuria more than 300 milligrams per day, you would not consider a safe donor. Why? That proteinuria in the general population has been associated with a higher risk of developing end-stage kidney disease on the long term. So protein spillage, that's probably not a great idea for you to donate. How about if you have hematuria or blood in the urine? So normally we're going to test the urinalysis like I mentioned, and we're going to check for hematuria. So hematuria is defined as 2 or 5 red blood cells per high-powered field. So if on your initial UA you have some red cells, we're going to repeat it. In the event that that hematuria persists, we can follow this algorithm. If you have blood in the urine, blood plus protein spillage, you probably are not going to be a good donor. And actually, you might benefit from seeing a kidney doctor as soon as possible. In the event that we repeat it and there's no longer any blood in the urine, there's no protein, it is okay for you to accept, to proceed in the evaluation of donation. And depending on your eagerness of donation, in the event that that hematuria persists, we can follow more testing that might include urological evaluation to make sure that there's nothing anatomically, like bladder issues, and ultimately getting a kidney biopsy to make sure that you don't have an underlying glomerulonephritis to explain this hematuria. What about kidney stones and kidney donation? So you're going to be excluded as a donor if you have a history of recurrent kidney stones, if you have sturvite or cystine stones, or if your 24-hour urine collection shows an increased risk for developing stones. In some cases, we might consider repeating after dietary modification, meaning you're a young, eager donor, you change your diet and your physical activity, and the repeat 24-hour stone risk profile shows that you are no longer considering the high risk, we might consider donation. I have done one of those cases and the patients have done really well. Also, we might accept you in the sense of in the history of kidney stones if you have a single stone that passed more than 10 years ago and right now you have no issues with stone, or if we find small asymptomatic stones on imaging findings and your stone risk profile doesn't show that you are at increased risk. So what about if you have a family history of autosomal dominant polycystic kidney disease and you still want to donate? Okay, the older, so we can do both things, either screen with radiological images or get genetic testing. So in terms of screening with radiological images, whether it's an ultrasound or a CAT scan, the older the potential donor, the more sensitive those imaging studies are going to be in ruling out PKD and vice versa. Meaning the younger you are, probably those imaging testing are not going to be too sensitive. So what about the genetic testing? So the younger the potential donor, especially below the age of 30, the more useful. Realizing that for genetic testing, we need to identify or have that genetic mutation identified in the recipient or in the family member to be able to test the donor. Typical example, we have a 25-year-old man with a family history of autosomal dominant polycystic kidney disease. We have an identified mutation and he has a negative ultrasound and he's interested in being a potential donor. I would definitely consider genetic testing for him to make sure that he doesn't have the same genetic mutation. And for completeness sake, in the genetic tests that are commonly involved, we have the PKD1 and PKD2, which are one of the common genes tested to make sure that you don't have predisposition to developing autosomal dominant polycystic kidney disease. So what is the surgery like, at least the recovery? So many of the kidney donor surgeries are done now laparoscopically, which means that it's minimally invasive and you're going to have a quicker recovery. You can generally expect to be kicked out of the hospital in day one. So our living donors, for the most part, are going to go home on day one. On rare occasions in which we have issues, for example, pain control or blood pressure issues, they might stay an extra day. But for the most part, surgery is done on day 0, and by day 1, you should be going home. Most donors resume normal activities after 4 to 6 weeks. You may not be able to drive for up to 2 weeks. One of the key things that I tell my patients is, are you ready to slam the brakes in the event that you need to? So usually it takes about 2 weeks for you to feel comfortable driving, and you might have lifting restrictions for at least 6 weeks to prevent the developing of hernias, for example. So what things you need to consider as a kidney donor? I want you to think about the donation process or how it might affect your daily activities. Who will serve as your caregiver and support you during the recovery? How much time off from work you will need? How will this, meaning the donation, affect your caregiving responsibilities, such as caring for your child, family, or an elder relative? Other important factors to consider: financial and insurance factors. So based on the National Organ Transplant Act of 1984, it is illegal for donors to receive payment. So the recipient's insurance will cover your medical expenses as a donor, and that will include your evaluation, the surgery, and limited follow-up tests and medical appointments. Realize that the recipient's insurance may or may not cover follow-up services for you if medical problems occur from the donation, including that even your own insurance may not cover these expenses either. So these are important things that we need to consider and ask. Other important financial and insurance factors. The recipient insurance coverage usually does not include transportation, lodging, childcare, or lost wages. Fortunately, we have several organizations, including the National Living Donor Assistance Program, the website or the address is here, which tend to help donors financing or at least with payment for some of these extra costs for you to be able to still donate. Some donors have reported difficulty in getting, affording, or even keeping health, disability, or life insurances. Premiums can increase, and if you don't have insurance prior to donation, realize that serving as a donor can be considered as a pre-existing condition when you apply for medical insurance. So I encourage you to talk to your employer about their leave policies, and I want you to carefully assess financial impact on lost wages. So as a medical community, we're trying to push for more living donors. So the Living Donor Protection Act was reintroduced this year in the 118th Congress by this representative. So in the event that you are in one of those districts, I encourage you to reach out and express your interest in passing this bill. So this legislation seeks to protect living organ donors from discrimination in areas of life and disability insurance. It also will prohibit life, disability, and long-term care insurance companies from denying or limiting coverage or charging higher premiums for living organ donors. This legislation will also help in clarifying that living donors may use FMLA time to recover from the surgeries and procedures involved in donation. And it will also help in directing the U.S. Department of HS or Human Health Services to update their materials on living donation to reflect these new protections and encourage more individuals to consider donating an organ. So in conclusion, living donation is considered safe if careful attention is paid to risk factors and for adverse outcomes. The integration of all a candidate's individual risk factors is an important goal of the evaluation. And I want you as a potential donor to make sure that you clearly understand your risks, including your medical, surgical, psychosocial, and financial risks before you consider donation. And that's it.
Thank you. Give me the mic. We don't have any questions right now on here, so if anybody in here has any, that I can use the mic and let our virtual attendees know. Your question, and I'll probably
But simply resuming normal activities after, 4 to 6 weeks, but driving after 2, what do you consider normal activities?
It depends. You can be walking around. If you
check. Just 1 second.
Yes.
Okay, thank you so much for that information on living donation. We really appreciate it. We do have a question for you. It's coming from our in-person audience, so thank you for the question. It is, you mentioned recovery time 2 to 4 weeks, but then a little longer for driving. Can you explain a little bit why that is?
So no, in general, it's shorter for driving. I mentioned that up to 4 to 6 weeks of restricted activity because depend. If your job is physically demanding, if you're a construction worker, chances are if you're not going to be ready in 2 or 3 weeks if your physical activities involve heavy lifting or strenuous activity. But if it's mild activities like driving, by 2 weeks you're definitely going to be able to do it without any issues. Like I mentioned, on day 1, you're going to go out of the hospital walking. You might be in some discomfort, but it's not expected that you're going to be requiring high pain medications, and we rarely, if at all, send our patients on narcotics. So with the pain is going to be not too bad, so Tylenol for the most part is able to control the pain, and you're able to resume normal activities. So it's the expectation that if it's light activities like walking, going grocery shopping and stuff like that, you should be able to do it pretty soon. But depending on the vigorousness of it, you might have to take care or take it slowly, particularly after those 4 to 6 weeks. With the main finding, the main reason being that you might have issues like a hernia if you strain or push too much.
Great, thank you. Thanks for clarifying there. Another question that maybe we could talk a little bit about, you mentioned some of the evaluation, what that looks like, the testing and things like that. What about the team members that a donor that is going through evaluation would meet as a part of their evaluation?
Yes, that's a great question. So you're going to be meeting a pretty big team, and it's actually the same team that will evaluate the recipient. So it's going to start from your coordinator. So you will have an assigned living donor coordinator. That's the person that from the get-go will be in contact to and will be directing you through the evaluation and the testing. That's going to be your right-hand contact with the team. After the living donor, you'll probably be the transplant surgeon, which is going to be one of the most important team players. The transplant surgeon will discuss at length the procedure, the surgery, and the risks. After that, you're going to be meeting with the transplant nephrologist, which will be myself. We'll talk about your medical risk of donation and your conditions that might put you at higher risk, and what is your end stage or long-term risk of developing kidney issues or problem. In addition to that, you're going to be meeting if you have any medical conditions, taking special medications, you might have to meet with the pharmacist. You will also meet with the social worker, with sometimes social worker to make sure that there's no any psychosocial issues that we talked about. And then you will be meeting with the independent donor advocate, which will make sure that it's safe for you to donate, that there's no coercion, and trying to help you out throughout that process. And that's about it in terms of the team. Good question.
Thank you. Are there any other questions in here?
Hi there, I'm Greg. So we talk about trying to improve the number of living kidney donors that we can open into this pool of available kidneys. What do you see as some of the major barriers for people when they're trying to get through to be a living kidney donor, or how do you think, what can we target to improve?
So I think that's multi-layer or multifactorial. I think the main important thing that we can do is talk about it and be a good advocate about living donation, just to start that conversation. Once we are able to start that conversation and we have some decent background knowledge, for example, with things that we talked about that taboo or that misconceptions can sometimes be overcome. So I think it's first lack of awareness. So if you raise awareness about the importance of donation and the quote-unquote safety of it, I think we're going to have more, potentially more kidney donors come forward across the nation.
Excellent, thank you. So I don't have any more questions, but since you did have the slide about the Living Donor Protection Act, I thought I would just say the PKD Foundation has an amazing group of volunteers. It's our Advocacy Champions Network, and this is one of our legislative priorities, so our advocates have been meeting with their members of Congress and talking about this bill and asking for support for it. So, this is incredibly important to the work that we do, and I just want everyone out there in our audiences to know that we do have a volunteer group that works on advocacy, and I'd love to hear from you. My name's Nicole, so give me an email if you're interested. Any other questions? What's your question so I can do it on the mic?
Are the slides available somehow for us to download them?
Great question. So we have a question about the slides being available. This session is being recorded, and it'll be available in the platform, the virtual platform, soon, and then in a couple of weeks we'll have it up on our website. We'll take all the recordings and put them on our website, and we typically promote that when those are ready. So you'll know through our social media or email.
So the slides will be out, right?
It'll be through the presentation, yes. All right, thank you so much. We really appreciate this information, and thanks for the questions.
Thank you.